Hey you guys, welcome back to our channel, Marriage and Medicine. So in this week's video, we wanted to talk about just kind of different patient experiences that you might face as a physician, whether that's in residency or attendinghood, or even medical school for that matter. Because I feel like this is something that you don't necessarily learn while you're in school or training, you kind of just learn by experience. So the first type of patient that you might get is usually someone who is rude, whether that's like they cuss at you, they call you out your name, what do you do, or like have you had that happen in any of your experiences?
Yeah, for sure. That's like a daily occurrence almost sometimes. So the thing is, it really depends on what the situation is, right? Sometimes you get a patient who's on drugs, all right, or they're having acute psychosis or something of that nature, and in a sense, you treat those patients differently than you would just like a patient who is being rude just because that's their personality. Those are kind of two different instances, right? So if you have somebody that's, again, under an influence or a psychotic, there's a true reason for why they're being the way they are. Like, of course, yeah, that's still not cool. It's not right. But in those situations, there's different methods that you can use to try to help de-escalate the situation. All right, so again, you start off trying to, again, get them into isolation, like get them in a room by themselves, give them time to calm down. You can try to verbally de-escalate. So again, just trying to talk with them and figure out kind of what it is that's making them upset. Sometimes all things fail, and that is when we get to the point where you have to sometimes give some medication to try to help calm them down, as well as, get security and all those kind of things. We really try to avoid that if we can. But once we get to a point where a patient is being a danger to either the staff around you or to yourself or to themselves, honestly, because that's how it is a lot of times, that's when we kind of go that route where we actually truly intervene. But a lot of these patients you really can just talk to, and sometimes you can kind of be a little bit of a give and take. It's like, if you do this, then we'll be able to do this for you kind of thing. Because most of the time,
bribery.
A little bit of bribery. Sometimes it's like, oh, you're hungry? Okay, if you allow us to go ahead and get this blood work and let us go ahead and do these things, then yeah, we'll get you something to eat, something to drink. Granted, yes, I mean, we're going to do that anyway, but it's really just trying to get some of those patients to just kind of cooperate a little bit better. And usually we can do okay with that. Now, when you get to the point where you're dealing with one of those patients who are just rude just because that's just them, you treat them a little bit differently,
right? Because they don't like what
like
you're doing, or like they feel like you didn't diagnose them correctly, or whatever.
Right. We get all those a lot as well, and a lot of that is really just conversation most of the time. So it's really talking with them and trying to get an understanding about what they feel as though is not being done appropriately. In some instances, you got to think like some patients only come to the emergency department when they're in severe pain, or it's kind of like their worst day of their life kind of situation. And so sometimes people can get out of character sometimes, and they can have increased heightened emotions, especially when they come to the emergency department and they expect a diagnosis. And sometimes there's nothing life-threatening going on. There's nothing that requires them to be admitted to the hospital. But again, they're still having pain, but we don't clearly have an exact reason why, and there's no exact reason what we can do to fix it. Some patients don't like that. And it's really a lot of conversations and saying things that you did do, things that you did rule out, and why you think it is this, it isn't this. So it's really a lot of just back and forth discussion, trying to see if you can kind of smooth it over a little bit more. But all in all, the main thing is do not take disrespect. Like, you're here to do a job. And again, you're here to perform a service. So if you get to a point where a patient is just being verbally abusive or things of that nature, and there's no clear medical reason for them being that way, you are okay you can discharge these patients if they are medically stable, right? You don't have to continue to go the extra mile if they are not allowing you to do your job appropriately, and if they're assaulting you verbally or physically, for that matter.
And yeah, I've heard you said like in some extreme cases they've had like instances where they will like ban a patient from a specific hospital, like not all hospitals in general, but just this one, like you cannot come back here because of how you acted. So like that is a possibility, I guess, too.
Yeah, you run that up the chain. And I mean, again, it just kind of depends on the situation. If they are just doing that, but they are knowingly being verbally or physically abusive, like, yes, that is not tolerated. Yeah.
So the next type of patient is the type that you get all the time. I hear stories about this all the time. Well, you know what I'm talking about. These are the patients that flirt with you, that are like a little too flirtatious, or they're like hitting on you, like trying to set you up with, you know, themselves or a family member, trying to get phone numbers, all that stuff. So you've had tons of experience in this area. So
that's always a good time.
What do you do in those situations?
Yeah, so these patients they're very interesting a lot of the times. Most of the time, I could not lie, the majority of these, well, not majority, I would say a lot of these individuals are also like the grandmas trying to hook up their niece or their daughter or something of that nature. And it's always funny because like you go in there, you talk to them the first time, and you know, they're asking all these questions like, oh, how old are you? Are you married? You got any kids? All that, blah, blah, blah.
Are you happy?
Are you happy? I'm like, so they'll ask these random questions. And like, you know, you don't have to give all this information, of course. Sometimes you talk with them, and then like you leave out the room, you go see some other patients, whatever, and you go back in the room, and it's like there's magically somebody else in the room that happens to be their daughter or whoever that individual was. So that's always hilarious. It's like, you see this ring on my finger, right? Like it's there, but sometimes they don't seem to care. But it is what it is. So those are always fun because it's almost harmless in a sense. It's just like grandma being grandma, unfiltered.
Yeah.
Just trying to look out for their family member.
Well, you've had it too where it's like grandmas that's not trying to look out for their family. They're like, look, if I was like 20 years younger.
I had that too.
They're like, oh, you a fine doctor. I'm like, all right.
Graham.
We are not here for that.
Very forward, and they're just unapologetic with it too, which is, you can't do anything but laugh sometimes because it's just hilarious, some of the things that these patients say. But in all seriousness, you do get some patients who are legit trying to hit on you, and that's kind of a natural thing. Like, it does happen, but you have to be very careful in these situations. Main reason I say that is, of course, you can't get in trouble if something escalated past professional status, right? If you start flirting back and possibly saying some inappropriate things, of course you can get in trouble for those kind of things if it escalates. We do a lot of very sensitive examinations, especially in the emergency department. And so, again, whether it's breast exams, pelvic exams, all those kind of things. And so always, always, always have a chaperone with you of ideally the same sex as the patient that you're dealing with. If it is, if it is a female, have a female chaperoning you. If it's a male, you can have a male chaperone you. That's okay. You can have a female chaperone you as well. But it is very important that you have a female chaperoning you if you're a male, examining another female, because that can be exactly where you get in trouble. And you get some patients who, again, will make inappropriate comments during the examination, which is unfortunate. And again, if you are feeling uncomfortable in those kind of situations, you are able to step out of the room and not perform the examination. Because again, you have a chaperone, you have somebody there to witness the things, so you're safe. Like, you have a bystander there.
Like, we're done here.
Witnessing
I'm gonna let you handle this.
But yeah, it happens. So
that's happened to you before.
Be careful.
It's weird.
it's
just weird.
It's like, this is not pleasurable.
Now is not the time for this.
It's really not.
And then you had the one, I don't know how it happened, but there was some person, I don't even know if it was your patient or if it was a family member of the patient, but they like kept calling, wanting to talk to you.
Oh.
They kept calling the hospital over and over and over, and somebody like took a message and was like, this person with this phone number keeps calling you and wants you to call them back.
That was so weird. So I was actually on a away rotation up in Pennsylvania. It's like, I don't even, like, that's not even my hospital, but I took care of a patient there, and somehow, like, they legit, like, while I was doing my away rotation, I was only there for a month. And so this individual apparently called the hospital like 5 different times trying to get in contact with me for who knows what, but
you know what,
called multiple times, and it got to the point where the EM clerkship person that I was talking with, they were like, they called me and asked me like, do you know this person? I'm like, I mean, I took care of her, but no, I don't know anything about her. But it was too much.
She
went straight stalker mode. Straight stalker mode.
I need to talk to you. Yeah. They're like, well, here's her number. He was like, I'm not calling her back.
Calling that back. What am I going to do and call her back for? Yeah. So yes, fun times.
So the next type of patient is like someone who suffers from some kind of substance abuse issue, whether that's like drugs, alcohol. I don't know what other options there are out there, but those types of patients, what do you do in those situations with them?
Yeah, so the first thing is understanding that these patients have a disease, right? There is a true disease that is underlying their addiction. So you have to be aware of your biases when you go into these encounters, and you have to be able to remove them, right? So if somebody's coming in frequently for either opioid addiction or they're coming in with intoxicated with their alcohol abuse, you have to not go into the encounter with this preconceived idea like, okay, they do this all the time, they're fine, we're going to just watch them here and get them out of here, right? Because again, you're going to miss some things. There is always a possibility maybe there was some trauma associated with it, right? So maybe they got drunk, fell down, hit their head, now they're acting like they're intoxicated, but it's not necessarily because they're truly intoxicated, it's because they, again, or they may be intoxicated too, but they also may have a head bleed, right? And so you can't miss those kind of things in these kind of situations, right? And so when you're dealing with these kind of patients, really go in and treat them like any other patient, right? Go in there and you do your full history. You do a thorough physical examination like you would with anybody else. And you try to see if there's anything else going along with it, right? Now, when it comes to assisting, there are some patients that come in with substance abuse that actually want help, right? They want to have those resources. They want to possibly go to a rehabilitation facility. And in those situations, most hospitals have social work that are very helpful in assisting with this. So hopefully you can reach out to them and you can help out. They can assist with getting them to where they need to be. But you also get others that unfortunately, they're just not ready. They were brought here because a family member found them drunk and they just wanted them to come to the hospital to get evaluated. Those kind of patients, you do everything you can to give them the resources to try to see if if they're ready to change. But sometimes you're just going to watch them until they become sober and you're able to discharge them home. You may see them again the next day, but that is unfortunately just kind of how it is in some situations, because you can only help those that want to get help, unfortunately, from that standpoint.
So like if somebody comes in, I know if they're drunk, but more so all you can really do is just kind of like wait till they sober up and then they could go, as long as they're okay. But if it's someone that like took, I don't know, cocaine or something, and they come into the hospital, like, I guess y'all's job is to just try to get them as sober as possible, basically, and then try to get them to be sent home? Or is it like you're trying to, I don't know, get them sent to a facility? I don't really know how that.
Yeah. So with most of these substance abuse patients, really when we talk about getting them sober, it's really like making sure they're alert, oriented, know where they're at, they're able to walk, they're able to eat without throwing up. And most of the time, if they can do all those things and they're not slurring their speech still, like they're back close to their baseline mental status, and they don't want to go to rehab, they don't want any of the extra assistance. If somebody can come and pick them up and they have a ride home, they can go home, right? But again, there's some of those other instances where people actually want some help. We have different resources that we try to provide. Sometimes it's limited based off of where you're living, based off your community, and those kind of things, what's available. So sometimes you get these patients where they just get a phone number that they should call in the morning to see if there's a spot available at this rehab place, which works for some people. Some other people, you end up just they don't follow through, and so you kind of lose them until they come back into the ED again.
So then what are, for people who like overdosed on something and were brought in, then what do y'all do, like, as far as, I guess they're eventually able to go home, or are they supposed to go somewhere? Like,
yeah, I mean, even if you like overdose on fentanyl or opioids and you get Narcan in the field, which is the reversal medication, and they get back to where they're alert oriented, they're not having any respiratory depression, so they're still breathing on their own, breathing appropriately. They get to that point and they're alert and oriented, they can go home. Yeah, because opioids.
I always wondered, because like with celebrities that overdose, you'll hear like so-and-so overdosed and is in the hospital, whatever. I'm like, okay, so after they do whatever, like to make sure they're okay, they just go home?
Yeah, I mean, it also depends on the extent. So like, of course, like you are doing a medical evaluation, right? So these patients could have, again, organ damage. They can have different kind of things associated with it if it is a severe overdose, and depending on how long they were down, maybe how long they weren't breathing appropriately, you can have a lot of disease processes associated with that. So you do have to evaluate for those kind of things. But the simple kind of like, I took too much fentanyl, somebody bystander called EMS. EMS got there immediately, gave Narcan, and they did not have any episode where they weren't not breathing. Like they were still breathing, just unconscious. Usually those patients do just fine, as long as they're, again, oxygen, all that stuff is fine. But so again, you do your full medical evaluation. Once they are alert oriented, back to their baseline, you can't force them to go anywhere. You can't force them into rehab. So you really, if they don't want to go to rehab, you discharge them back to wherever they came from.
Okay, so another one is the patient that comes to the hospital a lot. So it might be because they have something wrong or something that they feel like is wrong, and so they just come all the time, kind of like a hypochondriac. Or if they're someone who just comes, like there's not really anything wrong, I'm just like, I'm here, I don't really want to be anywhere else. So like, what do you do in those situations with them?
Yeah, those situations, those kind of patients, you have to be careful with also. First off, from a medical legal standpoint, because like you see these patients literally all the time. And again, a lot of these patients, they're probably fine. But again, you have to remove those biases, or be aware of those biases and address them before you walk into the room. Again, so you don't miss some certain things, right? So you try to treat them as all the other patients. You do your physical examination. You kind of make sure there's nothing new going on. And then you kind of see what it is that brought them here, essentially. And if it's something that does not require any further evaluation, you get to discharge them like any other patient, right? The issue where it becomes difficult with some of these patients is some of these patients are actually really sick, right? But they're always sick. They're like baseline sick, but there's nothing new that's really going on today that requires them being admitted to the hospital and those kind of things. So those patients, a lot of times you do your full kind of workup, you order your labs. Sometimes if they're just always having abdominal pain and you kind of have to rule things out, you get your CT scan, make sure all that looks okay sometimes. But those patients, a lot of times you have to do a little bit more with. And so at the place that I work, we kind of developed something called like a complex care plan for some of these patients, which is very beneficial in some situations, mainly because it can kind of give the next provider that sees them an idea of what they're commonly seen for, and kind of get an idea, like a little bit of the backstory without them having to read a whole bunch of charts to get an idea of what's been going on. We kind of summarize that in that kind of plan, just so you have an idea of what to do. And in some situations, again, when they arrive, sometimes you want to get a specialist involved in certain situations. And so you also kind of, sometimes this patient comes in here seeking certain things, certain medications. So basically be judicious with providing that medication kind of thing. Just is very helpful in being able to kind of help your guideline, or give you a guideline to help with treatment. But even with those, again, you have to be careful to make sure there's nothing new going on.
And then the last type of patient, or maybe just might be a person in general that you might encounter, is someone who is homeless. So they might be coming as a patient, or it might not be for that reason. So like, what happens during those situations?
Yeah, it's sometimes difficult because, again, bias goes into a lot of this as well. So again, just clear those before you walk into the room. But a lot of times with these patients, they're here for different reasons, right? So some people are very, very forthcoming with why they're here. They're just like, it's cold outside, I don't have anywhere to go, could you help me? And I respect those patients a lot because, again, sometimes it's a situation, sometimes they've been homeless for a while, sometimes it's something new to them and they really just have not been able to help navigate just their safety, right? They haven't been able to eat for the last couple of days, they haven't had anything to drink. So, I mean, sometimes those situations, you have to be a human, right? So if they need something to eat, if they're hungry, if they need some food, give them something to eat and some food. Now, of course, make sure they're not abusing the system, like coming in every single day for a meal. That's not what the emergency department is for. But we do try to help those individuals when we can. Again, we try to give a lot of social work resources to assist with that. There probably globally is a shortage of homeless shelters. Clearly, just based off of how many people you see on the street every day, there's a severe shortage of that. And so you can only help but so much in some of these situations. Like, again, you try to give the resources, you give them locations where they can go, You can give them a cab ride sometimes to these locations just so that they can be there first in line so that they can have a bed for the night. You try to help with those kind of things, but in some situations you're just really limited. And unfortunately, you have no choice but to discharge them back out to the street sometimes if there's no medical need for them to be there. Mainly because, again, we have sick patients that we do have to see, so we're not able to just allow them to stay and just take up a bed, basically. So in some situations, that's kind of what it ends up being. You get some patients who try to get a little bit more sneaky with their reasons for being there. You know, they kind of played the game for a little while, so they're like, you know, you come in for chest pain, and they have a history or whatever it may be, but really they're just here because they want to be in some environment for a little while. They kind of know to play the game, like, oh, I'm having chest pain, it's crushing. They kind of play it up sometimes. But of course you can't be jaded, right? You have to do the workup. You have to make sure they're not having a true heart attack and things of that nature. And you get some patients who, again, they just know how to game the system a little bit. And over time, they're going to kind of give themselves away that they're only here for certain reasons. And so you just have to kind of be careful of those patients as well.
They're like, all right, I'm good now. See you later.
Yeah, basically. Or you offer like, oh yeah, we can bring you in for this. They're like, no, I don't want that. I just wanted a meal. Like, okay, cool. Cool, thanks.
Yeah. Y'all's job is hard, but the things you see and the people you encounter in the different situations is like, I couldn't do it. I'd be like crying all the time, like, oh my gosh, I just don't know what to do. So like, that's why I'm not a doctor. It's I mean, I know people probably do feel like that anyway, but they like learn how to work through that to help somebody or to like, you know, continue on their day. But that is hard.
You have to compartmentalize a lot of things, right? You see a lot of sad situations, but you also have to understand that there's only so much that you can do. Again, you can't get somebody a home. That's just not in your wheelhouse. That's just not, you just can't do it. You're not going to be able to get somebody a job. Like, it's just not, you can't do it. So you have to work within your limitations and understand that there's only so much you can do to help some of these patients.
So thank you guys for watching. Hopefully that was helpful for anyone out there who might be in medical school or residency currently. And we will see you guys in the next video.